Without, of course, it's important to know that all the good music has already been written by people with wigs and stuff. So when talking about music, we're going to do it music style in 4 movements. The first movement will be a review of the anatomy and physiology of audition, which is the science of hearing and music processing. And my slides aren't advancing. There we go. And then we'll also understand the concept of musicogenic seizures. What are they? What are the various sources, subtypes, considerations, causes, and treatments? We'll understand the concept of ictal music generation with a few examples. And finally, we'll talk about some of the ways that music is actually used in the treatment of epilepsy. Spoiler alert, it's a little controversial. As with anything, follow the bouncing ball, boys and girls, because what would a talk about music be without a little bit of music? As far as disclosures go, I have none. I am just a poor musician, and I do mean that in the literal sense, which is why I am in medicine. I'm not very good at music, but I like talking about it. So without further ado, the first movement. A little bit about history of the brain and music. So the Greeks really were the first people to celebrate this. They were very aware of the way that music influenced the brain, the sedative and therapeutic effects it could have. Phoebus, actually the protector of music and medicine, was the father of Asclepius, the god of medicine. In Greek mythology, it was well written into the culture. There's the story of Orpheus and Eurydice. This was before Homer. Orpheus was given a lyre by his father, Apollo, and he played it so beautiful that even the trees and the rocks were entranced with this music. Now, Orpheus had a thing for Eurydice. He married her, and they were making beautiful music together. Unfortunately, Eurydice was dancing quite enthusiastically. She died in the forest, running with the nymphs from this. Orpheus was so sad after that. He played his lyre and sang out his grief so much that it moved everything in the world, including the humans and the gods. One of those gods was Hades, the god of the underworld. And he was so moved by this, he decided to let Eurydice back into the world of the living, back into the heart of Orpheus. Now, unfortunately, it had kind of a sad ending. Orpheus wasn't allowed to look at her. Eurydice died, then Orpheus died, and it was the whole big thing. But the Greeks were really into the way that music played out. In fact, so much so that they developed various different scales in music: the Lydian, the Phrygian, the Dorian scales, and all of those corresponded to a certain way to induce a behavior. Energetic music, serene music, all of this was well documented in Greek. And then Leloir developed the treatise of the specters, and he actually, in that treatise, details a man losing his urine upon hearing the music of a lyre. So this may be one of the first instances of hearing music and having a seizure. And then, of course, other areas of music were studied with medical physiology. Gretry looked at cardiovascular changes when people were singing. Mierzewski was actually the very first person to describe seizures being provoked by melodies or musical tones, but it wasn't really until MacDonald Critchley in the 1930s put out a very famous paper about musicogenic epilepsy that we really understood this as an actual documented medical condition. So what are some of the effects of music on physiology? Well, arousal effects are very well known and documented. There can be changes upon hearing music of skin conductance, cardiovascular changes. Music can affect our heartbeat, the interval between our heartbeats, our left ventricular ejection time, or blood pressure. It can increase our cerebral blood flow. It can cause us to feel tense, and in fact, tense up some of the muscles in our eyes and in our face. It can increase our metabolism. It can enhance our perception of special senses, sight and taste and sound. It can even exaggerate our knee jerks, believe it or not. Not to mention all of the emotional that comes with music: happiness, sadness, agitation, serenity, really a lot of things that music affects. So how do we process music? That's the study of audition. We will talk about that in the talk today. We'll also go into a little bit about emotion and waking levels, our appreciation of music, how it makes us feel when we hear it, What we won't get into so much is the aesthetic appreciation of music. I'm a big fan of Meatloaf, the 1980s rock and roller. Not everyone is, so I won't get into a bunch of arguments about that. Because, as they say, if it ain't broke, don't fix it. That's joke number 2 for the day. So the science of audition, how does it work? Well, our tympanic membranes are tuned so that when sound waves hit the tympanic membrane, it causes a vibration from mechanical force. And what that looks like is we have a sensation of that vibration of a string to a cause action through the air, which lands on the temporal lobe and then causes our tympanic membrane to vibrate. Human hearing, that vibration goes from about 20 hertz to about 20,000 hertz. And that's really the cycle of what we're able to hear. So what that looks like is we get a vibrational force on our tympanic membrane, and that in turn causes a vibration of the inner ear bones. And from there, we get an amplification. And here we see the bone of the stapes hitting the oval window, which then causes a churning of the fluid in the compartment beneath. And you see the round window then pushing in and out, converting pressure as we go. And in doing that, it churns this perilymphatic fluid that's inside. Now that fluid is very, either poor in potassium or rich in potassium. And as a result of that, the stress of potassium depolarize the hair cells underneath and then cause this electric signal to be generated. My apologies. If anyone does have a question, I'm a very informal guy. Please just put it in the chat, reach out, and we will address it. But yeah, I'll mute things a little bit. So anyway, that is essentially the science of audition. Is that fluid wave going through the cochlea, then transferring that electrical signal from the hair cell into the spiral ganglion, where then that signal is actually tonotopically organized. This is a really fascinating thing. A low pitch versus a high pitch, a different neurological signal gets sent, which allows us to detect the variety of pitches that come through our ability to hear. Low pitches, high pitches, all of that tonotopically organized nerve signaling gets maintained throughout the system of hearing. So within those vibrations, the hair cells get moved, the signal gets generated, and then it gets a bit complicated. So from the cochlea, we get the signal going to the cochlear nucleus, transferring up to the part of the brainstem, and then up through the medial geniculate nucleus of the thalamus, finally under our auditory cortex. And our auditory cortex is also arranged in a tonotopic fashion. So here, I'm not sure if people can see my mouse or not, but here we have Heschel's gyrus, which with these prongs moving apart the frontal lobe from the temporal lobe, exposing the insula underneath. The top part of the temporal lobe there in gold is our Heschel's gyrus, which is the superior temporal gyrus. As we can see on the second picture here, there is some subdivision of the superior temporal gyrus, which corresponds to various different areas of hearing and tone. And what that looks like is we get that transverse temporal gyrus or Heschel's gyrus, which corresponds to Brodmann's area 41 and 42. It has this oblique orientation, and as it comes out, it's organized from pure tones right at the heart, right at the center of things. And as it comes away from that primary auditory area, it's arranged in high frequencies and low frequencies. And as a result of that, depending on what the pitch of things is, it gets processed in a different area. And then when we go out further, from that pure tone, tonotopically organized area, we start to get into the association cortices, which helps us then process higher orders of music, something from a pure tone like a to an actual song. Now, blood supply to this area is mostly from the middle cerebral artery. We get a couple of branches, collateral branches from the posterior cerebral artery. And norepinephrine, actually, our excitatory neurotransmitter, acts in a slightly different way to decrease cellular excitability which I like to think of is it allows us to hear the music, calms everything else down so that we can really focus in on things. Now, when we get into higher order music processing, things get a little complicated even further. But I just wanted to talk about some definitions here. Tone, that's a steady sound, which is measurable. Like I'm not even going to pretend to have perfect pitch here, but a pure tone, that would be a tone. A pitch would be the difference between two tones. So a high and a low pitch. That is the frequency of that sound applied to a pitch standard, which I'm off pitch for anyone with perfect pitch in the audience. My sincere apologies. Contour would be the way that those pitches changes in time. So melody, as we also call it. Timbre, this is the difference between the sound that a tuba generates versus the sound that a string contrabass generates, or a flute and a trumpet. We can tell that the instruments are different, and that's because there are differences in timbre. Rhythm is that strong, repetitive movement, bum, 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 bum. And then meter is the way that that rhythm changes, bum, 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 bum. It gives us this different processing of things. And then, of course, there are all the memories, the emotions, happiness, sadness, peace, anger, fear, all of the things that music generates and makes us feel also gets processed in various different areas of the brain. Now, where those areas are, as I mentioned, this is very complicated. We won't get too far into the weeds, but it's essentially the temporal lobes in a belt area and the parabelt area around that. All of these surround that pure auditory cortex area, and as we get farther away from that, we're able to process more complex elements of music. There is bilateral representation, but it is mostly a right hemisphere organization, which people think, okay, left brain math, right brain music. There is some truth to that. It's a little complicated. Nothing's ever that easy. But by and large, music more on the right side as far as lateralization goes. Now, when we talk about where pitch and tone and timbre, all of these elements of music are processed in the brain, there's some very fascinating work here that's been done in a variety of different articles. I have numbers up here just because there are a lot of references. I'll show the references at the end, the numbers that they apply to. But pitch is processed, as you can see, mostly in the right. This is different from radiology. Left is on the left, right is on the right in this example. Pitch is processed in various different areas of the right temporal lobe, predominantly. Pitch pattern, the same deal. Both extend a little bit into the parietal lobe as well. Tonal structure includes those areas with a little bit of the insula and the frontal operculum as well. And then timbre, again, what makes a flute different from a tuba. We hear that mostly in the temporal region, as well as the parietal lobe, again, in those association cortices. When we think about time interval and rhythm, things like that are mostly processed in the right temporal lobe, but a little bit of the frontal lobe, a little bit of the parietal lobe, and even more so on the other side. Not sure what my brain looks like, because I have no rhythm, but this is what most people have organized as far as things go. And then my favorite, the recognition of music, what allows us to hear a song and affix some memory to it, that it's a familiar song that we've heard before, or even hearing elements of a song that make us think of something that may be familiar, even though the song that we're hearing for the first time is novel. Actually, there was just a lawsuit with Ed Sheeran bringing some of Marvin Gaye's elements of his music into his own music. And enough people said, well, you know, I love that Ed Sheeran song, but it sounds a lot like Marvin Gaye's. Anyway, I think Ed Sheeran was clear of that. But this is a true phenomenon, and it's because it gets processed in our memory areas of the brain. And then finally, the emotion that music makes us feel. No surprise, the limbic system is very, very well represented in this sense. And when we talk about the limbic system, we have this complex pathway where mesolimbic areas are affected by release of dopamine, which we'll talk about a little later in the talk. But it can cause this shiver down our spine. It can cause these physiological changes in us just from hearing the sensory intake of music. No surprise, the amygdala, the auditory cortex, various different areas of where music is processed are all involved in this processing. And what's really interesting is that they've done some fMRI studies, and the different types of music get processed in our emotions in different areas, in different ways. Music with high arousal and high valence, music that makes us feel wondrous and joyful and powerful. Think like the 18th century overture, gets processed in our temporal lobes in very strong fashion. Low arousal music that makes us feel peaceful or nostalgic. That's more in the mesial portions of the brain. Tension, tense music, sad music, all of those things get processed in different areas, which is truly fascinating, the way that the brain is able to parse that out. And when we think about the way that once the music does get to our temporal lobe, the way that we process it gets even more complicated. I won't get too much into this pathway. This is a famous picture from the neuroanatomist Netter, but essentially showing the way that when we think about music, process music, and even play music, there are a lot of interconnected pathways and networks as far as that goes. But to summarize, music is essentially processed on 3 levels: sensory processing, emotional processing, and again, the one we won't talk so much about, the aesthetic processing, what makes us like this musician more than we like that other musician. It does typically have a right temporal predominance, usually in the anterior and mesial regions, and they've looked at that with fMRI studies and SPECT studies. And then the way that those different areas network with each other helps us process things and get an idea of where things go. An overview of that again, one last time: from the ear, it goes to our cochlea, then to our brainstem, then to our thalamus, and from there it spreads, the thalamus being a great relay center to various different areas of the brain. It breaks it down to different elements and sends it to their respective areas of the brain, and then they talk to each other to make us register and feel it, and remember it, and do all the wonderful things that music makes us do. And again, that's just the ascending pathway. The descending pathway is quite a bit more complicated. Anyway, on to the second movement. Some men there are love not a gaping pig, some that are mad if they behold a cat, and others, when the bagpipe sings in the nose, cannot contain their urine. This was Shylock from The Merchant of Venice. This was thought to be William Shakespeare referencing a case of somebody hearing music and having a generalized tonic-clonic seizure in which they have incontinence of urine. There is another piece of literature. Since my remote boyhood, I have always been absent-minded while hearing the sound of the street vendor's flute. I fall sick when I hear the sound of the flute in the evening sun, although I do not know the reason why. This was Kung Su Chen describing what we think is probably a dialeptic seizure, or a petit mal seizure, where he hears a flute and goes into a petit mal seizure, or a complex partial seizure. This is essentially musicogenic epilepsy. So one great example of this, I'm not sure if you can hear the choir in the background, but was a 58-year-old woman. She had episodes of unresponsiveness at church. She would feel fuzzy. Her stomach would get upset. She would stop singing, look over, and her husband noticed that she had oral and manual automatisms, making gumming and chewing movements that we typically see during automotor seizures. Now, this would just happen when the music was playing at church, usually more when the piano was playing, and she would be confused. It would take her about 2 to 3 minutes to recover, and she would have no memory of the event afterwards. She did have an epilepsy monitoring unit evaluation where she was found to have left temporal epilepsy. Now, what's interesting is in playing church music to her, that would induce her seizures reliably every time. She didn't have a seizure outside of that. But if we played church music to her, it could trigger a seizure to happen. She denied any kind of emotion that the music made her feel. So it wasn't so much that she was feeling an emotional tie to the music, and that caused a seizure. It was purely the music itself. Now she was started on levetiracetam. Very rarely has any breakthrough seizure. She's very well controlled, continues to attend church. And this is an example of her EEG. So for the uninitiated, the first 4 lines here are the left temporal region. Next 4 are the right temporal region. 4 after that, left parasagittal, right parasagittal. And the last 2 lines here are the central chain. And as we see these squiggly lines start to come in the theta frequency, about 5 to 7 hertz. And that is indeed a seizure. It's arising from her, in this case, left temporal lobe, which then evolved and finished. And this happened reliably every time she heard church music when she was in the epilepsy monitoring unit. There is an electrodecrement here because you might notice, well, it looks like it's starting the mesial chain. Is this just a deep seizure that's starting in the memory centers? Could be, but there also might be some spread from the other areas of the temporal lobe as it goes through. Another great case, a 54-year-old man had his first seizure at 19, just a regular grand mal seizure, generalized tonic-clonic seizure. He later developed complex partial seizures or dialeptic seizures. He was started on anti-epileptic medications. His MRI looked normal. Unfortunately, he was in a car accident in 2006, probably from seizures. So he was brought into the epilepsy monitoring unit. We weren't quite sure what was causing his seizures. His EEG did show some left temporal spikes. Several days off the medication, no luck, no seizures. Everything was completely fine. That is until somebody turned on a radio. The song Born to Be Wild came on. Now, when that happened, about 1 minute after turning on the radio, he would stop talking, start staring off, and wouldn't follow commands. After that happened, he was very confused. He would kind of repeat the line, excuse me, and he would have no memory that any of that happened. At that same time, his EEG showed right temporal rhythmic theta activity, much like our last patient, but this time on the right side. It would spread to other areas of the brain, but it would reliably do that. What's really interesting is it would only do that when the song Born to Be Wild came on. Any other radio song wouldn't do it, but we played Born to Be Wild, and the gentleman had a seizure with that. We were able to replicate that multiple times. He underwent a right temporal lobe resection, and he's essentially been seizure-free since 2015. That begs us the question, what is musicogenic epilepsy? First things first, it is a reflex epilepsy. So reflex epilepsy is a rare form of epilepsy where a stimulus triggers a seizure. It's usually rapid. The stimulus happens, then the seizure occurs, and this can happen from a variety of different things. Photic stimulation is something we see very commonly. Flashing lights generate a seizure. We even test for that when we do routine EEGs. But a variety of other things can trigger a reflex seizure. Thinking about a certain thought, reading, the act of reading can cause a seizure. Eating, playing games, taking a bath in hot water can cause a seizure. Music, in this reflex epilepsy population, the stimulus triggers the seizure. Now, about 50% of the patients are able to recognize that happens. Not everyone, but generally, for it to be considered a reflex epilepsy, we have to be able to recognize that something happens and then a seizure occurs afterwards. And emotional and physical things can cause seizures as well. So it doesn't just have to be a reflex from some kind of act, but it could be a reflex from something that happens to us, a fever, losing sleep, that happens all the time. Hyperventilation, which is also something we test for. Drug, alcohol withdrawal, menstruation is well documented to cause seizures sometimes. Physical exercise, but generally the trigger must be seen enough in everyday life that it reliably seems to cause a seizure. So musicogenic epilepsy is a subset of that. The music causes the seizure. Seizures that are provoked by hearing music. They're often specific in nature, specific songs, specific artists, specific types of music, like Our Lady who heard church music, or our gentleman who heard Born to Be Wild, and that causes them to have a seizure. It's generally most reflex epilepsies come very quickly after they hear the stimulus occurs. Musicogenic epilepsy tends to be a little different from that. Sometimes it can happen up to a couple minutes after. So they hear the song, a couple minutes later have the seizure. We're not quite sure why that happens. but it's something that's been pretty well established. And then various triggers. You can have just a pure auditory tone, and that can cause a seizure. It doesn't have to be a really complex piece of music or anything like that. But of course, there are complex pieces of music, and then the way that we emotionally feel when we hear that music can also come. And Dr. Critchley wrote about that, as I mentioned, in his famous 1933 paper, where he first described musicogenic epilepsy. And there are a variety of famous cases, which I'll get into in a second. But first, I do want to try and underscore something. We're not quite sure whether it's sound, the sound itself, the pure sound, or the way that the sound makes us feel, the affectation. Hearing a song that triggers a memory or triggers an emotion in us, and it's that memory or emotion that then causes the seizure. From what we've studied, it seems to be more the latter. But when we talk about pure sounds causing seizures, they can be, like I said, anything from pure tones to simple music to very complex music. Now, one of the other interesting things is it's that interconnection with the primary cortex and the other areas where music gets processed. And there can be differences between consonance and dissonance. So consonance would be very beautiful sounding music, like something by Bach or Mozart, something that's very musically organized. It follows all the rules of music. Dissonance would be something, not to pick on the works of Arnold Schoenberg, but that sounds just very cacophonous and all over the place as far as music goes. Now, he's a brilliant composer who used math and matrices in his compositions, but it sounds very dissonant. And that differences in processing can come out in the way of where seizures happen. And to some degree, that could be because of the way it affects us. Happy, beautiful sounding music might activate our reward pathways, might trigger memories in our memory circuit, the hippocampus, the frontal lobe. It can spread to our autonomic area. A variety of different things can occur when we hear music. Now, next up is my favorite slide. These are a few perpetrators in the medical literature that have been described. Probably the most famous one is the first column, example, church bells. So during World War I, there was a small town in Europe, and the church bells would ring about every day around noon. And this resident of the city would have a seizure reliably. Every time she heard the church bells, she would have a seizure. That was also probably one of the first cases that was written about in the medical literature. But you can see a lot of different artists, a lot of different songs, a lot of different types of music, a lot of different emotional processing in music has been described in the medical literature as causing seizures. My favorite, or one that I think is most interesting, bottom of the second column, is the song Africa by Toto. Hear the drums echo in the night. One of my favorite songs. I love that song. Unfortunately, it's been described that somebody out there had a seizure every time they heard that song. That would be miserable. I love that song. Now, musicogenic epilepsy is very rare. It affects about 1 in 10 million people. So this is not something that we see all the time. Slightly more noted in females than males, about 1.25 to every 1 male. About 28 years old is the average onset, but it has been described all across the age spectrum. The youngest in the medical literature was a 6-month-old baby that heard any song by the Beatles and would have a seizure. Not the Stones, but the Beatles specifically. Fascinating case. And now most of these patients also tend to have some kind of exposure to music. They might be music lovers, they might actually be musicians, but a good amount don't have any interest or education in music at all, and they can still have this happen to them. Now, what's really interesting, in more recent years, there seems that there could be an autoimmune association to this. In fact, they've discovered an antibody, the glutamic acid decarboxylase antibody, which is an enzyme that converts glutamate, which is an excitatory neurotransmitter, to GABA, which is kind of a chill out neurotransmitter. If there is an antibody against that enzyme that makes the conversion, as seen by high titers in the CSF, it tends to have a pretty good association with musicogenic epilepsy. It also has an association, which we knew about a little before, to diabetes type 1, stiff person syndrome. So if we do in our workup of musicogenic epilepsy discover that there is an elevated GAD65 antibody, then we want to check for those other conditions as well. The trouble with that is, well, anti-epileptic medications are very effective against seizures. If it's caused by an autoimmune process, we generally need something more in the form of immunosuppressants. And when we do use that to treat musicogenic epilepsy, it's generally pretty effective. Now, what types of seizures occur from musicogenic epilepsy? Well, first of all, are these patients only seizing when they hear music? No, not generally. Only about a third of them have it exclusively from music. Most of them have other types of epilepsy where they may have spontaneous seizures, may have had seizures all their life, and then develop musicogenic epilepsy down the road. And most of them, if they do, keep both. There are some small examples of patients who have other types of seizures, and then later in life, they only seize when they hear music, and vice versa. Very small amount of people who would only seize when they hear music. Later on in life, their seizures start to come from a variety of different reasons. As far as the semiological features or what happens to patients when they have seizures, pretty much anything that can be a seizure that we see as a semiological feature can be described. So fear, auras, hallucinations, the rising sensation in the abdomen, apnea, oral manual automatisms, Jacksonian marches have been described, and of course, generalized tonic-clonic seizures and a variety of other things. So it's not that musicogenic epilepsy causes a certain type of seizure to happen, like a petit mal seizure or a grand mal seizure. Really, any type of seizure can happen. It's just different patient to patient. Now, again, to review a little bit of the localization, we are talking more the right temporal lobe than the left temporal lobe. Heschel's gyrus is generally involved. And because of that, the areas of those networks where those seizures spread to tend to cause the different features of the semiology of the seizure. So oftentimes, being in the temporal lobe, with Heschel's gyrus being in the temporal lobe, there's often a spread to the mesial temporal structures where we often get features of temporal lobe seizures like petit mal seizures or dialeptic seizures where patients may stare off, have gumming or chewing movements. That's been well frequently described. But again, because of the rich network of the way that we process music, a lot of different semiologies have been described as this goes. Now, there is a bit of a spread because of those networks. So you can see different elements of a seizure, just like with any seizure. You might have a petit mal seizure at the beginning that secondarily generalizes into grand mal seizure. You may be able to talk at the beginning of the seizure, but it may spread to the language area and stop talking. All of it tends to happen in different ways because of the way that these musical networks are organized in the brain. Now, what's interesting is there is a thought that because music makes us feel a certain way, it may be the autonomic responses to the music. Some music really pumps us up, gets our heart racing, makes our hair stand on edge, really triggers our autonomic nervous system. Is it the triggering of that system that then causes and propagates the seizures and makes it go, and maybe not even the music itself? That's been suspected in some patients, and they've looked at it. So they took a look at psychogenic musicogenic epilepsy, and that's not the same thing as a pseudo seizure or a psychogenic non-epileptic spell. These are epileptic seizures being caused by the psyche, the psychic response, the emotional valence that comes from the seizure. And they've been able to isolate that, try and get rid of the emotional factor with the music through various things. And they find that patients still have this autonomic disturbance when they hear the music, may become restless, tear up, start breathing heavily, or get emotional as a result of that. And then they've looked at the physiological responses as well. So for those patients who have autonomic changes, their heart may start beating really fast, or they may have their hair standing on edge or something like that. These patients, when they isolate that and find a way to get rid of those distractions, distract the patient even from hearing the music, maybe play it in the background, have them concentrate on something else, they still seize. And so that speaks to the fact that this is probably some kind of combination of both the pure auditory nature of the seizure, of the music causing the seizure, and also the way that we feel as a result of that. So in reality, there probably is a lot of overlap as far as this goes. Now, when we think about treating seizures, especially those caused from music, one thing comes to mind.
I said, Doc, it hurts when I do that. He said, don't do that.
The great Henny Youngman, king of one-liners, ladies and gentlemen. So yeah, if a certain song tends to trigger a seizure, just don't listen to that song anymore. As I mentioned earlier in the talk, if I had a seizure every time I heard Africa by Toto, that'd be really hard. I love that song. So sometimes it's hard to avoid this stuff. But in those cases, sometimes behavioral therapies, deconditioning, just listening to a little bit of the song, not quite enough of the length of the song to cause and trigger a seizure, but just a little bit of the song, then a little more of the song the next day, and a little more essentially is the practice of deconditioning. They have found that's effective in trying to treat musicogenic epilepsy, as well as psychotherapy. That can be very effective as well. Medical management with anti-epileptic drugs is obviously something that works pretty well too. These are seizures after all, so an anti-seizure medication is generally going to have some effect. Now, important things to keep in mind though, know your patient, know your audience. Some of the anti-epileptic therapies can actually affect the way that we hear and process music. If you have a musician who has musicogenic epilepsy, carbamazepine would not be a good medication. One of the reasons is it causes about a quarter tone of pitch disturbance. So for those musicians out there with perfect pitch, if they get put on carbamazepine, you can really screw up their career, because they'll start to hear things differently. They'll start to tune differently. Their conductors will think, wow, this guy's really fallen off as far as his performance goes. No, it's just an effect of the carbamazepine. Good news is if you stop it, it's reversible afterwards. Lamictal, which acts a lot like carbamazepine or works a lot like carbamazepine, has been studied. There don't seem to be any issues for that. There might be with Vimpat though. So all of these things are important to keep in mind. Know your patient. Surgical management is also really important. Like with any seizure focus, if it's a single focus and we can identify it, perhaps a surgery to remove that focus would be possible, in which case it generally would stop the seizures. But it's really important, like again, if you have a patient who's a musician, you want to test just like any other pre-surgical testing that we do on patients with language or memory. Testing music ability and proclivity will be very important in these patients. And there's a variety of testing that's been developed to try and do this, to try and look at different areas of the brain where they're processed. And so those are things that are important to check for, because the results can be devastating if we don't take that into account. So what's the differential diagnosis though? If people hear music and they have seizure-like episodes, are they always going to be epileptogenic or epileptic? Not always. Paroxysmal non-epileptic seizures or pseudo seizures are something to be considered. And even throughout the ages, some people who have been ascribed to have epilepsy probably didn't have epilepsy. They may have had other things. Michelangelo, the great artist, was thought to have epilepsy. Turns out it's probably just syncope from the heat of him probably standing and painting all those things for all that time. Handel, the musician himself, famous for his Messiah piece, he was thought to have epilepsy, probably just had cerebrovascular disease. So it's important to keep that differential in, because this can be mistaken for other things too. There was something that happened in the Middle Ages called dance fever. And people would essentially follow, like groupies, follow these minstrels around in the Middle Ages. Can you imagine minstrels playing the harp and the lyre and the lute, and going and having this following crowd that comes with them, and they would have wild dancing, and even mosh pits have been described in the Middle Ages, if you can believe that. Hopping, clapping along, hyperventilating, getting tachycardic palpitations. They would often faint. A lot of them hadn't slept in a while. They were maybe binging on wine. It did tend to be young unmarried women who followed people around. But this was a very well documented phenomenon that happened, and people weren't sure back then, are these seizures? Are these just something else that's happening? The Italians actually developed a dance style called tarantism that mimicked this, almost like they were dancing around trying to avoid a tarantula bite. And then another neurological term, St. Vitus's dance, arose from this as well, and that's described in patients with chorea. Now, thinking about that in the present day, it's kind of hard to imagine, because I can't think of any other musical phenomenon like those traveling minstrels where people would get really excited and faint or anything like that. There doesn't seem to be any example of that in modern day. If you can think of one, write me, let me know, send it in, because I can't think of anywhere that we've seen that before. Now on to the third movement. It's time and it was down till it down was there. Down you go till you go all the way. So hopefully that came through. Again, I'm not sure if the musical cues are working or not, but this gentleman was singing, and as he was singing, he was having a seizure on the EEG to the left. This is a famous case in the Green Journal, which is the journal of the American Academy of Neurology. That's essentially what musical seizures are. So in this particular case, this was a 58-year-old man with a pituitary tumor who had it resected. It was complicated by bacterial meningitis, and he would have ictal seizures where he was singing When It Doesn't Matter Anymore by Buddy Holly came on. When he would have the seizure, he would have this forced singing and sing that song. He came from a musical family, played multiple instruments. He did have a preceding seizure disorder, other types of seizures in the past, like we kind of talked about, as possible. In fact, sometimes when he played the piano, he would have seizures, so a musicogenic epilepsy in that case. But he developed these seizures where he would start to sing when he had them. This was his EEG. You can see he had onset of seizure in the right temporal region, and then that would spread to various other areas of the brain. So what this is it's essentially a musical automatism. Now, this can happen where people have, when we think about automatisms, we may think of people staring off, not being aware of their surroundings, maybe having gumming and chewing movements or picking movements of the hand. An automatism is essentially something that you do without thinking of. And some people sing when they have them. Some people hum. Humming, which is a non-articulated, wordless way of singing, we think coming from the mesial temporal region, that's been described as well. So somebody has a seizure, and as a result of the seizure, they start humming.